Good afternoon. I'm Dr. Deborah Toppmeyer from Rutgers, Robert Wood Johnson Medical School, Rutgers Cancer Institute of New Jersey. I'm delighted to be here today and to discuss hereditary cancer syndromes beyond BRCA1 and BRCA2. Although I will focus the majority of the discussion today on hereditary breast and ovarian cancer syndromes, it's also important to know family history, other cancer syndromes that are important as they impact on screening and your management. So the topics I'm going to discuss today is what is genetic counseling, risk factors, sporadic versus hereditary cancers, the importance of collecting your family history, hereditary breast and ovarian cancer syndromes, Lynch syndrome, which is a hereditary colon cancer syndrome, and the advent of new panel testing. We are not just screening for individual genes anymore, but rather we are doing panel testing, which encompasses multiple organs that can be affected by a germline mutation in a specific gene. And I will speak to that towards the end of my talk. So why is genetic counseling important? And really undergoing counseling by a trained genetic counselor who focuses in cancer genetics is critically important in identifying family history and also identifying the appropriate testing. Again, when one is diagnosed with cancer, particularly breast cancer or any early onset cancer, it is important to identify possible hereditary cancer syndromes. The genetic counselor is also critical to facilitating genetic testing, locating appropriate research studies for eligible patients who have been identified with a mutation. In addition, those who have been affected with cancer can be identified as patients for new therapy specific to tumors developed in the setting of a hereditary cancer syndrome, such as PARP inhibitors for those individuals who have a tumor related to either BRCA1 or BRCA2. It's important to discuss the current screening and prevention methods available if one is identified as harboring a gene mutation. And also these particular centers really provide psychosocial counseling and support for patients who are seen as well. It is also critically important that when one thinks about genetic counseling, it is not just for that individual, but genetic counseling these results impact the rest of the family as well. And for an individual who is diagnosed with cancer and then identified with a hereditary cancer syndrome, this could be invaluable information for individuals in the family who have yet to be diagnosed and can offer them opportunities for early detection or prevention. Critical in thinking about hereditary cancer syndromes is that all cancer is genetic, but not all cancer is hereditary. In fact, the majority of cancer that develops is not because one has inherited a gene from their mother or their father that confers an increased risk. But rather, we also need to understand that the majority of cancer is through acquired mutations versus inherited mutations, meaning that a gene was passed on by your mother or your father at the time of conception that increases your risk for cancer in the future. And just to put this in context, one of the reasons and one of the tip-offs that a cancer may be hereditary is an early onset of disease in an individual. So if you think about the development of cancer and a sporadic cancer, one, for example, is born with two functional sets of genes. And these particular genes may be important in a tumor suppressor gene that is important in DNA repair. And if one is born with two copies that are functional and over their lifespan undergoes multiple hits, which we do as we age, and one of those genes gets knocked out, then you still have a functional gene. It is only later on potentially that second gene gets knocked out, and the lack of this tumor suppressor gene then leads to unchecked cell growth and tumor development. On the other hand, with hereditary cancer, one is already dealt at the time of birth with one hit. So they only have one functional gene. So you can see that it takes fewer events to knock out that one functional gene, and hence cancer can occur earlier on in one's life. And once again, one of the tip-offs is early onset of cancer in families. And it's also critically important to understand that the paternal lineage is equally important as the maternal lineage. So a mother or a father can pass on a BRCA1 or 2 gene, for example, to their offspring. And in this particular case, the father is the carrier. And so there is a 50-50 chance that any one of the children will inherit that gene. And typically, hereditary cancer syndromes are inherited in an autosomal dominant pattern. What that means is if you get the gene, that you do have a high likelihood of expressing the disease, because BRCA1 and BRCA2 are highly penetrant genes. Once again, I want to really underscore the importance of the paternal lineage. So just coming back to sporadic, familial, and hereditary cancer, the vast majority of cancer is sporadic in nature. About 65 to 70% of sporadic cancer is due to acquired mutations. On the other end of the spectrum, only about 5 to 10% of cancer is truly hereditary. Again, a gene inherited from your mother or your father that confers a lifetime risk of developing cancer. Somewhere in between is familial cancer, and this can really be a combination of modifier genes, environmental factors, where you see more cancer than expected in a family, but you can't identify a specific mutation. And again, it is very important that we take a full history, and I'll speak to that in a moment, including environmental risks, exposures, employment risks, et cetera, when one is thinking about their family history. So just kind of in a pictorial form here, if on one end of the spectrum of sporadic cancers, you can see that environmental lifestyle issues probably play much more of a role in sporadic cancers, whereas genetics in hereditary cancer. So even if one lives a totally healthy lifestyle, although this is certainly encouraged, your genetics really wins out here. So keeping that in mind is why women many times decide to take certain paths in terms of managing their risk. So cancer risk factors include genetics, as I just talked about, environment, race, and ethnicity. There are certain ethnic groups that have a higher versus lower risk of certain cancers. Gender, obviously women are much more at risk than men for breast cancer, although 1% of all breast cancer is seen in men. Age is one of the most significant risk factors for cancer when it comes to sporadic cancer. The longer we are around, the greater the likelihood is that our DNA can take hits either from our lifestyle choices, environmental exposures that increase our risk of developing breast cancer, colon cancer, lung cancer, et cetera. Lifestyle choices are also critically important. And in this one particular study, it was the investigators found that 42% of all incident cancer cases and almost 1/2 of all cancer deaths were attributable to evaluated risk factors in the United States in 2014. So although sometimes we feel that we don't have the power to control our destiny, in many cases we do. And one of the primary goals of our education and outreach at the Cancer Institute is educating young men and women about their risks through a very innovative program that we have called Decoding Cancer that really teaches them that they can make a difference. Their sun exposure, smoking, what they eat, how much they exercise, their alcohol consumption. All of these issues are very important in terms of their cancer risk, but just overall health risk. Again, the majority of individuals do not die from cancer, but actually die from cardiovascular complications, stroke, heart attacks. So it is also very important to remember that as we're thinking about our lifestyles. So characteristics of hereditary cancer include early age of onset, usually before age 50. Also, typically there are several family members diagnosed with the same type of cancer, or there can be a constellation of certain types of cancer in the same family, more than one primary cancer in the same individual, or presence of a rare cancer such as male breast cancer, sarcomas that are unusual that can be associated with certain cancer syndromes, and multiple generations affected. Once again, some families are not as informative as others, and that is why we have a lower threshold today than years ago of offering genetic testing to individuals affected with cancer. So, what are the general criteria of who should be tested? It is especially helpful for individuals or families with any of the following: breast, colon, or uterine cancer diagnosed before the age of 50. Once again, age is a harbinger, if you will, for a potential underlying cancer susceptibility syndrome. 3 or more relatives with the same type of cancer on the same side of the family. Ashkenazi Jewish ancestry in the presence of breast, ovarian, pancreatic, or prostate cancer, and even melanoma. Multiple types of cancer in one individual, multiple colon polyps, bilateral breast cancer, ovarian, fallopian tube, or primary peritoneal cancer, metastatic prostate cancer, pancreatic cancer. All pancreatic cancer is now, individuals are offered genetic testing. Male breast cancer, particularly an Ashkenazi individual, should be offered testing. Triple negative breast cancer, all women 60 and under with triple negative breast cancer, regardless of family history, should be offered genetic susceptibility testing. But despite saying that these are the criteria for testing, we have really started to branch out beyond those criteria because we realize that we are losing or not identifying certain individuals that don't meet these criteria, but may harbor a mutation in a cancer susceptibility gene. And hence a more recent recommendation that all women diagnosed with breast cancer be referred for genetic counseling, and not necessarily testing, but be offered the opportunity for counseling. So it is very important that you know your family history and you also know your risks. So what do we mean here? It's important to collect your family history. You know, many individuals are doing this sort of more out of interest of their ancestry, but you can use various online methods for collecting family history, such as Ancestry.com, to build your family tree. And it's really very important that we go back multiple generations on both sides of our family. So collect the appropriate family history details, which includes the type of primary cancers in each relative, the age of disease onset in each relative. I am far less concerned about a woman who comes to me regarding concern about her family history because her mother was diagnosed with breast cancer at age 75 than someone who says their mom was diagnosed with breast cancer at age 45. Cancer status in first, second, and third degree relatives makes a difference. So grandma on my paternal lineage who was diagnosed with ovarian cancer has a significant impact on how I would assess an individual's risk for harboring a mutation, for example, in BRCA1 or BRCA2. Cancer status in both sides of the family. It's not additive, but we need to look at both sides of the family. Ethnic background on both sides, other medical findings, benign tumors, developmental delays, et cetera, that may be associated with certain cancer syndromes, such as a PTEN mutation. It is important to try to confirm the cancer diagnoses with records. Very frequently, an individual will say to me, well, my grandmother had uterine cancer, and it turns out to be a particularly different type of cancer, specifically ovarian cancer. So documentation of these cancers is very important. And for cancer risk assessment, the number of family members living long lives without cancer is just as important as those that have developed cancer. So we want to know the affected, but also the unaffected. And outside the scope of cancer, it's really important to know your family history. Again, not as it only relates to cancer, but heart disease, diabetes, asthma, mental illness, hypertension, alcoholism. So all of these medical problems are important to identify in our family members because they can also point to certain other risks for us that may impact how we manage those risks in the future. For example, glaucoma, this is very important that someone who is not thinking about getting routine ophthalmologic exams may do so because of this family history. So confirming family history information, try to obtain written documentation of cancer diagnoses in the family. Pathology reports are really so helpful and absolutely critical when we're trying to make assessments. Genetic test results that anyone else in the family have had, medical records and treatment notes also are important if there are autopsy reports or a death certificate. Many times death certificates are not as informative as we would like them to be, but certainly this is helpful. And why is this important? It helps us verify a verbally reported pedigree. So if you look at the pedigree on the left, this is the mother with stomach cancer, a offspring with prostate, and another offspring with bone cancer. And actually, when we had confirmation of those pathology reports, it actually was that mom had ovarian cancer diagnosed at 43 and died at 49, and the daughter had breast cancer diagnosed at age 45, and the son did not have prostate cancer. So this very much impacts on how we view this family history. And years ago, before we had even cloned the genes, we would use family history many times to make recommendations relative to risk-reducing surgery, and obviously having confirmation of these verbally reported pedigree is very important. Less so today. It's important to document risk factors as well, including employment-related risk factors, lifestyle risk factors, smoking, diet, alcohol use, obesity. As you know, many of these risk factors increase cancer risk. What are the side effects and risks from medications or medical tests and prior infections and viruses that may have been contracted by the individual that may also increase risk? The facts. Once again, the majority of cancers occur sporadically. Most people who develop cancer have no family history of that cancer. 75% of women who are diagnosed with breast cancer have no family history of breast cancer. Only 5 to 10% of cancers are truly hereditary, and mutations in the BRCA1 and BRCA2 gene account for about 30% of all hereditary breast cancers. So I just want to review a few pedigrees for you. This would be a typical sporadic breast cancer at age 75, not other individuals affected, but even if there was another individual affected who was in their 70s or had postmenopausal breast cancer, this would not be a particular pedigree that I would be, in family history that I would be concerned about. Now here, you're starting to see more individuals affected with breast cancer. The individual at age 55, we're getting a little bit younger here, but once again, nothing that screams out, but there could be some shared exposure by family members or some modifier genes that they may share that increase their risk for developing breast cancer. And finally, if one looks at hereditary breast and ovarian cancer, this is certainly a no-brainer. Early onset of cancer, 2 breast cancers in this particular individual. And so this is certainly someone that we would absolutely be very concerned about. And if we did not even identify a gene that caused this cancer, we would still counsel this family as a high-risk family. Now, when you start to factor in Ashkenazi Jewish ancestry, this is very, very important as well, which I'll get back to. And if you look at this family history, once again, even if the individual wasn't of Ashkenazi Jewish descent, it would not make a difference because you have early onset breast cancer coupled with ovarian cancer. And the real question is, what is Martha's risk and what do we do in this situation? So in terms of Ashkenazi Jewish ancestry, these are individuals of Central or Eastern European ancestry. There are 3 common founder mutations identified in BRCA1 and BRCA2 that really account for the majority of BRCA1 and BRCA2 mutations. The incidence in the Ashkenazi population is high because these are founder mutations, because the mutations occurred in an isolated Jewish population long ago and became more common. And so that risk is 1 in 40, which is very different from the population risk of a BRCA1 or BRCA2 mutation. So the question is, should all Ashkenazi Jewish men and women be offered BRCA1 and 2 testing? And one can certainly make an argument for doing that, but there are certainly insurance issues that one needs to consider as well. And many insurance companies will not pay for testing outside the scope of the quote criteria that I previously discussed. So what are the cancer risks associated with a BRCA1 or 2 mutation? Obviously, breast cancer and ovarian cancer risk is markedly increased in those that carry a BRCA1 or 2 mutation, with the ovarian cancer risk being higher in BRCA1 mutation carriers. There is also an increased risk of pancreatic cancer and prostate cancer in those who harbor a BRCA2 mutation, as well as male breast cancer. There is an association of melanoma also in BRCA2 carriers. Once again, the risk of ovarian cancer is not as high in BRCA2 carriers, but it is still unacceptably high, and that is why we do recommend risk-reducing salpingo-oophorectomy after childbearing between ages 40 and 45 in BRCA2 carriers and between ages 35 and 40 in BRCA1 carriers. So just a simplified referral guide. All ovarian cancer should be tested except for germ cell and borderline tumors. All male breast cancer, all metastatic prostate cancer, all pancreatic cancer, all breast cancer if Ashkenazi Jewish, breast cancer less than 45 or breast cancer less than 50, with another breast cancer, ovarian cancer, pancreatic in a relative. 3 strikes any, breast, ovary, prostate, pancreatic cancer at any age. But once again, as I said, we are really starting to broaden the inclusion of individuals, and anyone diagnosed with breast cancer can be considered for genetic testing at this time. They don't need to meet these more strict criteria. So coming back to this particular pedigree, Jan does test positive for a BRCA1 mutation, and her sister Martha also tests positive. And why is it important to test Martha? What are the opportunities when one tests an individual who is affected with cancer and they're identified as having a mutation of significance, a deleterious mutation? It allows Martha to take certain steps that she otherwise wouldn't have taken if she didn't have this information. So screening and prevention options, more frequent screening, incorporation of different screening methods, such as in addition to mammography, we will incorporate MRI screening as well. We recommend initiating screening at a younger age. We also offer chemo prevention in certain situations, for example, tamoxifen, raloxifene, aromatase inhibitors, which we usually use in the treatment of breast cancer, but have also been effective in preventing breast cancer. Less strong data in those affected with a BRCA1 or BRCA2 mutation, but certainly worth discussion. And risk-reducing surgery, particularly risk-reducing salpingo-oophorectomies, removing both the ovaries and the tubes. Again, just to review this, very important, clinical breast exams beginning at age 18 and every 6 months. We typically do not recommend testing women, however, with a known mutation, depending on, unless there is very early onset disease in the family, before age 25. Self-breast exams, we recommend monthly. MRI exams, if one is identified as being a BRCA1 or 2 carrier, we do not recommend mammography until women reach age 30, but we would recommend annual MRI beginning at age 25. We also discuss the option of risk-reducing mastectomy. And as you can see here, there are proactive measures that we can take, not only screening and increased surveillance, but really risk-reducing surgery that can impact on the risk of developing ovarian cancer in the future. So that includes prophylactic mastectomies, risk-reducing salpingo-oophorectomies, oral contraceptives can modify ovarian cancer risk, but typically in women with BRCA1 mutations, we do recommend early removal of the ovaries, and oral contraceptives in the BRCA population can also increase breast cancer risk depending on the data one looks at. So what are the myths about hereditary cancer? Even if I have the genetic mutation, I can't do anything about it. Cancer runs in my family, so I already know that I probably have the genetic mutation. A woman can't get the genetic mutation from her father. I've already had cancer, so knowing whether or not I have the genetic mutation isn't relevant for me. Well, all of those are myths. And again, it is very important to offer genetic testing. Obviously, any individual affected with cancer has a right to say no, but we need to give them the opportunity. It is also important, when possible, to test the affected family member first, because if there is a mutation in the family and they have the disease, they have the strongest likelihood of testing positive for that gene. To determine the risk of additional cancers. So a woman who is identified as being a BRCA1 carrier, we know that her risk for contralateral breast cancer is very high, and her risk for an ovarian cancer is also very high. We are also learning more about the survival of women with cancers caused by BRCA1 mutations, and that they can actually live longer and show increased sensitivity to chemotherapy. Certain cancer treatments may be more effective, and this includes our personalized precision medicine initiative. In some cases, it answers the question, why did I get cancer? Again, the majority of cancer, however, is sporadic, and it provides the most accurate risk assessment information to at-risk relatives. So if an individual like Jan had tested positive, which she did, it also helps us counsel Martha on testing, and testing, if positive, what to do about it. So what are the possible results of a genetic test? A negative test result, negative for the genes that were tested, but it is important to consider if there is a known mutation in your family, and I'll talk about the two different types of negative tests. We see this a lot, a variant of uncertain significance, and it is unknown at this time whether that genetic change is harmful. At this point, when we see a variant of uncertain significance, we view that as a quote negative result, and we don't act on that in the same way we do a positive result. And so this leads to a lot of misinformation when that is not explained clearly to the individual who is tested positive for a variant of uncertain significance, or a positive test result, positive for a gene that we know increases the risk for cancer. So an uninformative negative, no mutation was detected in the family. The cancer risk remains elevated based on family history. If possible, have affected family members tested, and there are technical limitations. A true negative only occurs when a mutation has already been identified in the family. So the cancer risk for that individual, for the most part, returns to the general population risk. So having a known mutation in the family and testing negative for that known mutation is far more informative than just undergoing testing without a known mutation in the family with a high-risk family. So just to review once again, the variant of uncertain significance, this is a change in the gene or that may or may not increase your risk of cancer, and it will require additional analysis or data. And years later, when more information comes in regarding these benign, well, what looks like variants of uncertain significance, they can be reclassified as benign or deleterious. So we do not recommend a change in medical management unless this is reclassified as a deleterious mutation in the future. And most variants of uncertain significance are benign. So if gray is spelled G-R-A-Y or G-R-E-Y, we understand that it is the same and it doesn't change the meaning, so it doesn't change the protein. However, if it's G-R-I-Y, that obviously changes the meaning and the protein. So this is very important when you're thinking about these variants of uncertain significance. There can always be these polymorphisms that occur, and these variants occur that do not have significance in terms of the protein function. So let's just quickly go beyond BRCA1 and 2 and briefly discuss Lynch syndrome and the multi-gene panel testing and some of the newer genes that we've identified in the breast ovarian cancer syndrome space. So hereditary non-polyposis colon cancer or Lynch syndrome is a defect in mismatch repair. So the DNA, and think about these genes as spell checker genes. They are there to repair mistakes as replication occurs. So repetitive sequences can slip either at the parental DNA strand or the newly synthesized daughter DNA strand, and these particular genes are important for repairing those strands, because if there is a deletion or insertion, the protein does not necessarily work properly. And we can actually look for mutations in mismatch repair genes by actually looking at immunohistochemistry of the tumor, because mutations result in the loss of expression of the proteins in the tumor tissue. And we can actually stain for expression of the protein in the tumor tissue for MLH1, MSH2, MSH6, and PMS2. The absence of the staining in tumor tissue equals the loss of protein expression. And if we screen positive with the tumor, we do refer those patients for genetic counseling and diagnostic germline mutation analysis. About 20% of colorectal tumors have abnormal IHC, but not all of these are due to Lynch syndrome. About 1 in 5 that screen positive will have Lynch syndrome, and 5 to 10% there is a false negative rate. And cancer risk in individuals with Lynch syndrome, particularly colon cancer and endometrial cancer, are the highest risk, but certainly one can see ovarian cancer, stomach cancer, hepatobiliary cancer, small bowel, CNS, sebaceous neoplasms. So in particular, when one is identified as having HNPCC, we do recommend, routine screening, including colonoscopy, and certainly at some point we do recommend prophylactic hysterectomy and oophorectomy as well, given the endometrial and ovarian cancer risk. And I just want to end to make sure we have, over the past several years, there has been a great deal of focus on the BRCA1 and BRCA2 genes as they relate to breast cancer risk and HNPCC. But genetic testing for 84 genes associated with hereditary cancers across 8 major organ systems, including breast and GYN cancers, GI cancers, endocrine cancers, genitourinary cancers, brain, nervous system, sarcoma, and hematologic, are really important to understand. And as such, we do have multi-gene panels, and we really typically do not test for single gene or syndrome testing anymore, and it's difficult to justify now. So if you have had testing in the past just for BRCA1 or BRCA2 and it was negative, it may be time to update your testing and reconnect with a genetic counselor for reconsideration of panel testing. Genetic tests now look at dozens of genes related to cancer, and there has been a significant decrease in the cost and turnaround time for gene-specific testing as well. We do also have new genes that we have identified, and we realize that our interventions are warranted based on the level of risk. For example, with PALB2, we now know the risk can approach that of BRCA2, and certainly a discussion regarding prophylactic mastectomy can be entertained. There are also lower risk genes such as ATM, CHEK2, for example, that we may just recommend MRI screening rather than prophylactic surgery, but these are discussions that we do have with patients, and certainly it is important when we think about BRCA1, 2, Lynch syndrome, BRIP1, RAD51C, and D, consideration of salpingo oophorectomies. Again, keep in mind there are high-risk genes, moderate risk genes, and newer risk genes. And these are all considered when we do panel testing, and the genetic counseling portion of this is critically important to put this in context for patients so that they can make appropriate decisions. And so in the end, I just want to refer you to certain websites for additional information. And once again, at the Life Center, if anyone wants to make an appointment in the central New Jersey area, we are happy to see one and all. Thank you for your attention, and I'm happy to answer any questions.